Hello again. We will talk about penetrating trauma to the neck here. So we will talk about the anatomy here, and anatomy is very important for penetrating neck trauma, even important relative to other surgical topics. And I try to go over the anatomy in most of these surgical talks because it has importance, but even more so for penetrating trauma to the neck, the anatomy is very critical. And it's not only critical in knowing that when you have penetrating trauma to the neck, there are lots of anatomical structures that can be injured, but it's actually going to be important to know about the anatomy for management because a lot of the algorithms, including the one I'm going to give you, divide up management based on which zone is injured. And it's pretty apparent which zone is injured in penetrating trauma because when a patient comes in, you will be able to see, just looking at the patient, well, the gunshot wound entered here and the exit wound is there, or the knife wound is here, or the knife is sticking here. And so this is where the zone is that's injured. Compared to with blunt trauma, the patient hits their neck against a steering wheel or runs up against a post or something like that, it's not obvious macroscopically looking at the patient without imaging where the injury is at. So with penetrating trauma to the neck, the zone of injury is going to greatly impact how we initially treat the patient and ultimately how we manage the patient. So anatomy is extremely relevant to penetrating neck trauma. So those zones of the neck can be divided up into three zones, and it's based on two anatomic structures. The angle of the mandible, which is the angle that your mandible makes. I don't really know any better way to describe it than angle of the mandible. And then the cricothyroid cartilage. Where is your cricothyroid cartilage? You should be able to feel it. So if you're a man, you should be able to easily find your Adam's apple, maybe even if you're a woman too. But if you feel down to your thyroid cartilage, which would be the Adam's apple or whatever you call the Adam's apple equivalent in a woman, that is your thyroid cartilage, not your cricothyroid cartilage. If you palpate down just below that to the very next prominence, and it's only about half a finger length below it, yeah, it's like half a finger length, there's another prominence, and that is the cricothyroid cartilage. Now, in between the thyroid cartilage and the cricothyroid cartilage, you have what's called the cricothyroid membrane, and that's actually another very important anatomical landmark because that is where you're going to stick the needle in if you do a cricothyroidotomy for intubation technique. But the cricothyroid cartilage is where you would draw the line to divide up zone 1 and zone 2. So the cricothyroid cartilage, everything below that in the neck is zone 1. Between the cricothyroid cartilage and the angle of the mandible is zone 2, and everything above the angle of the mandible and the neck is zone 3. All right. So the neck is oftentimes divided up into anterior and posterior triangles. So when we think of anterior and posterior triangles, you've got to get down where these two very important muscles are. And those muscles are the sternocleidomastoid and the trapezius, which coincidentally are both innervated by the spinal accessory nerve, cranial nerve 11. So the sternocleidomastoid, let's talk about what the anterior triangle is. So the sternocleidomastoid is a muscle that, like its name would imply, goes from the mastoid process to the sternum, and from the mastoid process to the clavicle. So there's kind of two heads to it. You can see here there's two heads, two bodies to it. I don't know what the anatomical term is, but you got two parts to your sternocleidomastoid muscle. So the anterior or more medial part of the sternocleidomastoid runs right here. This is going to form part of your anterior triangle. And then also in your anterior triangle is the angle of the mandible right here, and then the midline. So if you get your midline, angle of the mandible, anterior part of your sternocleidomastoid, this forms your anterior triangle. The posterior triangle is formed by the more posteral or lateral part of the sternocleidomastoid, the clavicle, and then the medial part of the trapezius. The trapezius kind of wraps around the neck and comes down to the lateral part of the clavicle right here. So the sternocleidomastoid, it's pretty easy to feel where that muscle is. It's a pretty prominent ligament in the neck, but it's responsible for turning the head side to side. And that might actually help you palpate the sternocleidomastoid. The trapezius helps you shrug your shoulders. So here's zone 1, 2, and 3. Your cricothyroid cartilage is right here. Your angle of the mandible, it's kind of hard to see. It's actually, I drew the line here, but really the line would be drawn like that. But I wanted to give you a good line here. So really the line is like how this red line is up to here, like that. Okay. So everything between that line and the cricothyroid cartilage line is zone 2. Above the angle of the mandible, zone 3. Below the cricothyroid cartilage, zone 1. All right. Okay, so here starts my illustrations, and I hope this is good enough for you. I'm not a good artist, and I really mean that. You don't know how many times it took me to draw this, so I got it at least to my liking. So this is your skull here. This is your, here's your skin, kind of transposed over the skull. This is the hyoid bone, and then this is part of your clavicle, and you're kind of looking at this laterally. So you're looking at it from the side. Okay, so here's some basic muscles, your sternocleidomastoid and trapezius. And I know this is not attached to anything that looks like the mastoid process, but please just humor me here. So your sternocleidomastoid, trapezius, and then you also have these two muscles here, which are considered kind of the same muscle, digastric. And so you can kind of, and then here's omohyoid muscle, and this is just going to be important. We're going to talk about the anterior triangle, and there's 4 triangles within the anterior triangle. For the USMLE purposes, as long as you know the anterior triangle, you're good, but 99 percentile material or good stuff to know to impress your surgery attending, you should know these 4 triangles in here too. So I just introduced these 2 muscles here, the digastric and omohyoid, to help divide the triangle up. So here's your omohyoid muscle, kind of comes from the hyoid muscle down here like that. So, and then your midline. So you got your anterior triangle right here, from your medial part of your sternocleidomastoid to the midline to the angle of the mandible, and then your posterior triangle, which is from your trapezius, lateral part of the sternocleidomastoid to the clavicle. So looking at the anterior triangle, what structures come through here? Well, most importantly, you've got your common carotid artery, internal jugular vein, cranial nerve 10, which is your vagus nerve, and these come together associated with the carotid sheath. And then you have cranial nerve 12 kind of coming down through here around and then up into where the tongue is, and that's your hypoglossal nerve. So within here, this is the carotid triangle. Right? This is the biggest part of your anterior triangle. You also have the muscular triangle here, which you've got your thyroid and parathyroids within there. And then you have the submandibular glands up here. So where the thyroid and parathyroids are, this sits in the muscular triangle, which is your omohyoid, I believe your midline, and then the part of the sternocleidomastoid. So all these are 4 triangles within a bigger triangle. So this is your muscular triangle here. And then you've got your submandibular triangle, and that would just be below the mandible. And then your digastrics, and I believe your hyoid and midline. So within here is the submandibular gland. And then you have another triangle, and that's formed right here. That's the submental triangle, and I think there's just lymph nodes in there. Okay, so these are just 4 triangles within one triangle. The 4 triangles within the anterior triangle. And then your posterior triangle, what do we have going through here? These aren't in perfect anatomical position, so don't berate me for that. But I just want to note that they're kind of coming through this posterior triangle. You've got your subclavian artery and your external jugular vein. You also have the brachial plexus and cranial nerve number 11, which is going to go, like I said, to your sternocleidomastoid and trapezius for motor innervation. So with the occipital triangle, you can have damage to any of those. I believe with this supraclavicular triangle, it's primarily would just be damage to the to lymphatics, but there's probably stuff in there too. But this is also divided up into 2 different triangles. So I would just make sure you at least know the anterior triangle and the posterior triangle for USMLE purposes. That should be good enough to get you by. But this is how a surgeon may pimp you if you're going through your medical school rotations. So these are, when we have injury to the posterior triangle, we're definitely thinking anything with the brachial plexus, cranial nerve 11 injuries, and if there is bleeding, subclavian or jugular injuries. For anterior triangle, we're thinking more concerningly common carotid artery, internal jugular vein, and then vagus arteries, or vagus nerve. Okay, so that's anatomy. Hopefully I didn't make that too confusing. So initial approach to neck trauma. Typically with penetrating neck trauma, we've got gunshot wounds and stabbing. So if you're working in an inner city setting, you're going to see this a lot. I did my training in central Illinois in a city that we saw lots and lots and lots and lots of these. So medical students got their fair share of going through intestines to look for gunshot wounds. When we are thinking of neck trauma, the number 1 thing that is of concern is the airway. Of course, airway is always a concern, but even more so with neck trauma because your airway goes right through your neck. So any signs of hypoxia, stridor, neck distortion, or hematoma in your neck should be intubated immediately. That makes perfect sense for hypoxia and stridor, but what about hematoma formation? Why do we intubate that immediately? I mean, if they're talking to us, if they're saturating fine, if they're not, if they don't show any overt signs of difficulty breathing, why do we need to intubate that? Hematomas tend to grow, and if you have a hematoma that hasn't really been checked over really well, or you haven't done any kind of like angiography, what you likely have is a possible growing hematoma. And so this should be intubated. And the reason is because let's say you're to go on and see another patient and the patient's not intubated and your patient is sitting in the ER room, not observed, which they're usually not in the meantime while they're waiting for tests. They may start to get compromise of their airway if the hematoma gets large enough to where it can cause that pressure against the airway. So rather than wait for an emergency and get rushed in by a nurse and have to emergently intubate, which can be a much bigger problem than if you are just doing a non-emergent intubation, we're just going to intubate these patients so that we don't have any problems come up in the future. We're preventing a bigger problem. All right? So blunt trauma, primarily we manage that based on symptoms and CT results, whereas with penetrating trauma, we usually have a good idea of where the injury is based off of how we see the patient. Where is that knife wound? Where is that gunshot wound? It doesn't mean we're not going to get further tests, but the zone of the injury is going to really help us with management. So what can be damaged? The larynx can be damaged. So that would cause things like hoarseness, dysphonia, changes in the voice. edema, pain below the hyoid bone, crepitation over the thyroid cartilage. The trachea can be damaged. That could cause a tension pneumothorax, upper chest crepitation. The esophagus can be damaged. So here we would see hematemesis, dysphagia, odynophagia, soft tissue crepitus. If you have a wound, you may see saliva leaking out of it. That's a really big concern towards esophageal damage. And then pneumomediastinum, that's something that you'll probably see on X-ray or CT. Another thing that you may hear described to you is a sucking neck wound. And all that is that the patient is breathing and air is going through the wound or coming out the wound. Vasculature, this is important. So expanding hematoma, weak or absent pulse, bruit, thrill, or symptoms consistent with a CVA. And it really is a CVA because you get damage to your carotid artery. It's basically like getting a stroke, because if you have not enough flow going up to various parts of your brain, it's just as if you were to get a clot. The nerves, the major concern is the cervical spine, primarily with blunt trauma. We're not as much worried about the cervical spine if we just have like a knife wound. Remember, protecting the cervical spine is bone. So that's a concern with blunt trauma, a big concern with blunt trauma, and it's a concern with gunshot wounds. With knife wounds, not so much, but you're always concerned about the cervical spine. Cranial nerve 10 is your vagus nerve, so we're thinking of voice abnormalities, vocal cord asymmetry here. It's something you might notice the vocal cord asymmetry if you're intubating the patient. Cranial nerve 11, sternocleidomastoid or trapezius weakness. When you're doing your physical examination, the patient is usually going to be in a C-spine collar, so you're not going to be able to check the sternocleidomastoid because they have to move their neck. But the trapezius is responsible for shrugging the shoulders, so you should be able to check this by asking them to shrug their shoulders. Cranial nerve 12 is easy to check for. You just look for tongue deviation. The phrenic nerve is, you'll see asymmetry of the diaphragm on chest X-ray or on CT. You may also see use of accessory muscles of breathing or difficulty breathing, ultimately, because those accessory muscles aren't quite as good as the diaphragm for breathing. And then any problem to the brachial plexus, particularly if you are having injury to the posterior triangle. Brachial plexus is pretty much anything arm related. All right, penetrating trauma to the neck is defined as any injury of the neck where the platysma is violated. The platysma is a very, very, very superficial, thin muscle that covers most of the neck. So this is the technical definition of penetrating trauma to the neck, although it should be pretty obvious what penetrating trauma to the neck is when you see it. The neck is very vascular, and you have very important vessels that go through the neck, including vessels that supply your brain. So vascular injuries can be life-threatening, but there's going to be pretty much bleeding. There's going to be bleeding, either obvious bleeding or hematoma formation in any penetrating trauma to the neck. I mean, you can't shoot yourself in the neck or stab yourself in the neck without bleeding to some degree. But whether or not that injury is life-threatening determines on how deep and how severe the injury is. So what we're concerned about vascularly is hematoma formation. Remember, that causes airway compromise or can eventually cause airway compromise. Transection of the vessels. So if you have transection of your carotid artery, that will cause symptoms consistent with stroke. If you have transection of your jugular veins, that can also cause major problems, including exsanguination. So all three of these things are big problems. As always, you should resuscitate the patient first. That's always our first step. In addition to maintaining they have a secure airway, you'll want to give normal saline and blood products if necessary. And I should have boldfaced this and put this in yellow font and underlined it and put exclamation points here. Do not ever remove an impaled object if the patient is anywhere but in the OR. Why? Because the impaled object is probably stopping more bleeding from happening. So if the patient is in the ED You're not going to remove anything that's in their neck. That sounds like it might be something that is really basic and obvious, but you'd be surprised at how many people may forget that and do it, thinking, oh, geez, I have a knife sticking in me. I'm going to take this out. And you want to tell the patient, don't do that. So not only do you not want to do that, but you want to tell the patient, please don't take that out of your neck. So don't remove any impaled object. Can't stress that enough. Indications for immediate neck exploration. So are we going to do surgery on all patients who have penetrating trauma of the neck? No. Are we going to do surgery on virtually all patients who have penetrating trauma to the neck? Yes. So virtually all, not all. So what are the indications for immediate neck exploration? Look at these complicating factors. So shock. If a patient has shock, they're going to be going to the OR, but after we resuscitate them. You never send an actively shocking patient to the OR. If they have an enlarging hematoma, you're sending them to the OR. If they have active bleeding that you can't stop, you're sending them to the OR. If they have subcutaneous emphysema, or that crepitation, you're sending them to the OR. If they have dysphagia, hoarseness, stridor, you're sending them to the OR. So that's a lot of things. Also, if they have zone 2 penetrating injury, which if you look back to that anatomy, zone 2 is everything between the angle of the mandible all the way down to the cricothyroid cartilage. So that's most of your neck. So if they have zone 2 penetrating injury, you're sending them to the OR. So this is a very, very wide class here of people that need to be sent for immediate neck exploration. And remember, by immediate, I mean after you resuscitate them and everything else. But these patients will need immediate neck exploration. Everybody else, so if it's zone 1 or zone 3 penetrating injury, and they're not, they don't have any of those complicating factors, then these patients can be worked up with more tests. So what are the additional tests we need? Well, of course, we need labs. Those trauma labs include CBC, a BMP, a blood type and cross-match, alcohol levels, and toxicology at least. And then in addition to that, it depends on where the injury is. So if it's zone 1, meaning below the cricothyroid cartilage, you should get a CT angiography of the chest. That makes sense because the chest is where the injury probably is going to be seen at, because this is below the cricothyroid cartilage and maybe involving something below that. If it's a zone 3 injury, meaning above the mandible, the angle of the mandible, then you'll get a neck CT with contrast. So this is pretty much rehashing everything that we went over. So resuscitate the patient first with normal saline. Don't remove any impaled object. Your indications for immediate neck exploration, which include these complicating factors, which you should know about, and then a zone 2 injury. Zone 1 injury, they get CT angiography. Zone 3 injury, they get neck CT with contrast. Follow-up tests depend on what injury is present based on your findings. So these could include esophagoscopy or gastrographin esophagram, because remember, gastrographin, because if you have a penetration, a perforation, you don't want barium getting out. That would be done for esophageal problems. Tracheobronchoscopy can be done for problems of the airway. Aortic arch angiography can be done. So there's lots of different things that you can do. Okay. So here's your algorithm. Trying to simplify this down. Hopefully did not make this more complicating for you. So if there's penetrating trauma to the neck, you're attending to your ABCs, fluid resuscitation, intubation, etc., as well as attending to any other emergent problems that might be present. And then what you're going to ask yourself at this point is, what zone is the problem at? You should ask yourself, are there any absolute indications for neck exploration? So shock, enlarging hematoma, active bleed that can't be stopped, subcutaneous emphysema, dysphagia, hoarseness, stridor, any of those, off to the OR. At that point, then you can ask yourself, what zone is this in? If it's in zone 2, off to the OR. If it's in zone 1, go ahead and get a CT angiography of the chest. You can also, based on the findings, consider esophagoscopy, esophagram, aortic arch angiography. Based on your findings from there, you can either go to the OR for a chest-neck approach or observe the patient. All of the patients with penetrating neck trauma, though, should be admitted. Zone 3, they're going to get a neck CT with contrast. You can consider angiography, tracheobronchoscopy, pharyngoscopy. These aren't conclusive lists of tests you can consider. I'm just giving examples here. And these patients can be either sent to the OR or observed based on their findings. What you really need to know for the USMLE, I'm just going to boil this down, is the immediate treatment, and then know what patients need to go straight off for OR neck exploration, and that's going to be patients with these absolute indications and patients that have zone 2 penetrating injury. Otherwise, they can get CT angiography of the chest for zone 1 or neck CT with contrast for zone 3. All right, and that's all. If you have any questions, please feel free to comment.